Okay, we have 10 participants. A lot of us. All right, should we get going?
Yep.
I think we should. Okay, this is going to be a very brief introduction to Ian. Ian is somewhat retired, but still doing a lot of work at RAND. He's still the co-director, which he's going to mention, I think, of the RAND Center for Collaborative Research in Complementary and Integrative Health. And he's done a lot of work on complementary and alternative medicine. He's a sociologist, and he's professor emeritus at the UCLA School of Dentistry. One of the most interesting things about him is that he was once president of the Canadian Memorial Chiropractic College. And back from 1999 to 2003, he co-taught with me a very short course for the clinical scholars at the time called Theory in Health Services Research. So I've worked with Ian for a long time. He's a great collaborator and very productive person. So we're really looking forward to your talk. Thanks, Ian.
Okay, so I'm not going to waste any time giving you any more introduction about our center. I was asked to talk about the Delphi method, which is kind of interesting because what I'm going to talk about is actually called the modified Delphi method. And as you'll see from the title, I have actually entitled it the RAND UCLA Appropriateness method, and it's called RAM. And that's because the Delphi method at RAND is used as a step to something else. And it's actually a step to actually doing appropriateness studies. So what I'm going to do in today's presentation is kind of three things. I'm going to walk you through the Delphi method or the modified Delphi method. I'll give you a little bit of history about why we developed it and what its purpose has been. And then I'm going to walk you through two recent studies where we've used it, because we still do use it, which are both sort of innovative in how we've adapted it. So we've entered the new age of patient-centric research, and we've tried to modify this method to take that into account. And as I pointed out, historically, we didn't do that. I did send you, you've all got the PowerPoints anyway, but you can, if we don't get through all this, I hope to leave about 15 minutes at the end, at least for questions. So I'll leave the questions till the end if I can. So now if I can get this to move now. Just one moment. Okay. So the history of this is kind of interesting because it sort of starts around the 1970s in effect. The NIH developed what's called the NIH Consensus Development Conference, which was using expert panels at NIH, and their purpose was to try and make sure that clinical practice was informed by scientific research. So the idea was to bring scientists into the NIH, into these expert panels, and that they would then have a discussion about the evidence for a certain procedure, and that's come up with a set of guidelines, and then the idea was that then all clinicians would follow it. And so the thing about the NIH Consensus Conference was that they were scientifically based, and most weight was given to the scientists, not to the clinicians, right? So its purpose was actually to try and make sure that what was being practiced, particularly in medicine, actually was scientifically sound. Now here's what was wrong with it. Here's the challenges by doing it. First of all, you can only use that method if the issue can be resolved by existing evidence. Now, if you think about all the things in the health field that cannot be resolved by evidence, I mean, if you think how many random controlled trials do we have on all the procedures that have been used in medicine, you'll figure out pretty quickly that unless you have a meta-analysis for most of them, you can't actually argue that they're all that evidence-based. And the number for which we have a meta-analysis is quite restricted. So it meant that they were sort of limited in what they could cover. They focus on efficacy and safety, and very seldom did they look at effectiveness, because they tend to focus on RCTs, and they weren't looking at what happens in the average practice. They're looking at what happens in trials. They focus on research findings. The next part was really important. They actually forced consensus, so that I've been on these, and I'll tell you, they lock you in a room and you don't get out until you all agree on what the recommendations are going to be. So the one I was in, we didn't get out till 2 or 3 o'clock in the morning. They started feeding us ice creams at 12 o'clock. I think they thought the sugar boost would help us. But anyway, we were stuck in this room in Washington until we got an agreement. The downside of that, which RAND figured out pretty quickly, is if you force consensus, you get agreement on the lowest common denominator. So you'll only get recommended those things for which there's total agreement. And again, that means that, you know, you're taking something for which there may not be a lot of evidence to begin with, and now you're actually restricting it even further by only having those things for which you can get agreement. There's a problem about the panel composition, and there's a lack of impact on physician behavior. So what happened was RAND looked at this and sort of critically thought about it. And it happened again in the 70s and 80s, particularly 80s and 90s, where some other research was coming along that raised a very real issue. And that was the research that started to show vast geographical variations in medical procedures. So you'd have 2 counties alongside each other. The epidemiology of the population would be identical, and you might get a 6-fold difference in the rates of tonsillectomies or appendectomies or whatever. And so people started to figure out there's something wrong here. If the population in terms of the epidemiology is identical, you shouldn't have these variations. There's not only variations in the procedures, there's incredible variations in the cost. So that raised the issue that some of this cannot be appropriate. And so RAND thought, well, okay, how do we study appropriateness? How do we decide which of this stuff is appropriate and which isn't? And then when we studied the NIH consensus panels, RAND did some really interesting studies looking at how much was physician behavior being actually modified or changed by the NIH consensus panels. And what they discovered is not at all. They're virtually having no impact on medical practice, whatever. There is a reason why RAND thought that happened, and we tried to do something about it. And that was because if a physician looked at these expert panels from NIH, they don't see a person like themselves on the panel. What they see is researchers and scientists, and they say to themselves, well, they've never practiced a day in their life. You know, why would I follow them? You know, they didn't see opinion leaders that would be similar to them in terms of being clinicians and practitioners on the front line represented in those panels. And then the last thing that was happening at that time, of course, was a real escalating in cost. And RAND kind of thought to itself, and Bob Brook has stated this quite often, that if you could actually get rid of inappropriate care, you probably could have covered all the uninsured in America. Because when we started doing appropriateness studies, it always turned out about 30% of the care being given turned out to be inappropriate. And if you think of what the cost is for that inappropriate care, then that was a great drain on the system. So that's the background that we had, and that's the background in which we what RAND and UCLA did was to come up with this modified Delphi system, which I'll talk about in a moment. But if you look at the 2 approaches, the NIH one on the left and the RAND one on the right, you can see they're both kind of evidence-based in the sense that they both do systematic reviews. So they will look at what evidence exists, right? On the left, though, the panel of experts tends to be the people that either produce the evidence or that are researchers and so on. And so they are confined pretty much to that evidence base. What they do in the NIH panel as well, which is kind of interesting, is they hold an open meeting where people can come and give evidence or make a point or argue in favor of something. They have this selected panel that it goes away and gets locked up in a room until they get agreement. And then that panel can invite other experts to come and present. So someone's pointed out that the NIH Consensus Development Conference is like a town hall meeting, a scientific meeting, and a scientific conference all rolled into one. So they have, and then at the end, they demand consensus. So that's the NIH one. The RAND one is the panels do have research and scientists on them, but they also have clinicians. And so clinical acumen and clinical experience is also part of the evidence that can be adduced in a discussion. So if I'm on the panel and I'm a very experienced clinician, I can actually say, I don't care what the lit says, I've been doing this for 30 years, or let me tell you about the case I saw yesterday. Let me, you know, and as long as you can convince the rest of the panel that your clinical acumen is correct, then you can actually insert clinical experience. So RAND tries to look at the scientific evidence like the NIH, but it doesn't ignore clinical acumen. It's a closed discussion amongst the panelists. No one else gets to actually participate in it. And they don't force consensus. They measure the degree of consensus and they report on it, but they don't force it. So they don't have to all agree. So on any given recommendation, we can say this was the degree of consensus, this was a degree of uncertainty, or this was a degree of disagreement, right? And at the end of it, what we do with the results, or what we did with the results in those days, was to take the things that they agree about, a set of indications for doing something, and we go out and we'd actually use it to measure a rate of inappropriate or appropriate care. And I'll describe that more fully in a moment. But that's the difference between the two. So the RAND one actually developed, and it was a RAND UCLA one, which I'll show you in a minute, developed as a reaction against the NIH one. So that's the difference between the two. So they have a slightly different purpose. They're done a little bit differently, but they both use expert panels. So what RAND did, and it's called the RAND UCLA approach, and it's either called RAM or now it's called RUAN, R-U-A-N, which I'll give you a slide in a minute. But historically it was called RAM, but it meant RAND UCLA because it was developed by both RAND and UCLA. They combined two things that already sort of existed. There's a thing called the Delphi method, which I'll explain in a minute. They combined that with expert panels. So they took the expert panel idea that NIH was doing, and they took a Delphi method, which had been around since the 50s. And the Delphi method was a way in which people get to rate things anonymously by themselves. Then the results are shared with the people who have done the rating, and then they re-rate it. And then you get to see if you know how other people rate things differently from you, do you change your mind about it, right? So that's what a Delphi method does. And what RAND did was a modified Delphi method. And what we do is the same thing. People rate things privately by themselves at home, but we bring them together in a face-to-face meeting. And it's that face-to-face meeting that initially at RAND was why it's called modified. But the Delphi method had been around since the 50s. It's widely used, not just in this sort of application, but in all kinds of fields. It's quite famous, it's well known, it's been analyzed a lot, it's anonymous, they do statistical analysis of the ratings, and it's an iterative process. You keep sending it back and getting them to redo it, and you can do it as many times as you like. It's usually at least 2 rounds, but it can be more. But that's an iterative process. Dmitry Kodakov gave me this slide, which is why his name's at the bottom. Then what RAND did then is it modified the Delphi process, as I told you. Not only did it get them to do it at home, it brought them in together face-to-face, and we discovered pretty quickly that face-to-face meetings get different results. And we combined it with this thing about expert panels. We also introduced rating scales that we could use to rate a procedure, about whether you thought a procedure should be used or not. And we have ways of determining the consensus, but we don't force it. And so the modified Delphi became the major initial step in moving towards measuring rates of appropriateness. And as I told you, it was called RAM. But the R means RAND UCLA, RAND/UCLA. But I guess a lot of people got annoyed because UCLA never appeared in the name. So now, and in fact, in our publications recently, we refer to it as RAND. And so now that means RAND UCLA Appropriateness method. There is a user manual that is available through RAND. You probably can get it online. It was actually produced by the RAND office in England, I think it is. But anyway, it is available. There is a manual. But I'm going to walk you through the method and show you how it's done. First of all, we've got to start with a bit of a discussion about what we mean by the appropriateness of care. And I suppose where good RCTs exist, there isn't a real big question about the appropriateness of care. If there's a meta-analysis and you've got 15 or 20 RCTs, and they all say the same thing, then it's pretty clear what you should be doing if you're doing evidence-based practice. When that's not the case, and that's usually not the case in most of medicine, you get either therapeutic anarchy, where everybody does whatever they like, and just defends it to themselves, or you get tyranny of tradition, everybody does what they're taught in medical school or whatever, or you get dominance of revered authority, where certain gurus or recognized experts dominate and their opinion dominates. And you can see the last one happens all the time. And as you know, in evidence-based literature, the opinion of experts, if you look at the way that people do systematic reviews, is actually rated as the lowest form of evidence, right? Anyway, that's the background, but here's what appropriate care is. It's when the right patient gets the right care at the right time for the right condition and from the right provider at a cost they can afford. So just very briefly, that's really, when all of those things line up, you can probably say the patient's getting appropriate care. But you've got to remember that inappropriate care can actually be underuse. You don't get it when you should get it, when it's the most appropriate care for you. It can be overuse. So it's kind of interesting that inappropriate care can affect the rich just as much as the poor. You can be totally overtreated because you've got so many resources or money that they overtreat you, right? So it can be both underuse and overuse. So it's not just underuse. Everybody thinks of underuse, but it can actually be overuse. Using a procedure when it's not indicated, but because the people who got the money to do it, doesn't constitute appropriate care either. What's the appropriate definition? Well, it's actually quite open in the RAND UCLA method. And often we're not exactly sure how each person on the panel decides this equation here, but the equation is that the expected benefit, health benefit, must exceed the risk by a sufficiently wide margin that the procedure is worth doing. That's the only definition the panel gets. That's what when you're trying to decide if this is appropriate, you've got to decide, is the health benefit worth the risk, right? And they're asked to consider it in a typical practice, not in a trial, but just in a standard everyday practice with people that are not experts, just the average kind of physician or practitioner. And you do it in the year that the study's being done. So given what we know about, say, back surgery in 2021, is this procedure something that the average back surgeon should do or not? That's kind of what the guideline is for doing it. Okay, so then what RAND did then was it created these panels of 9 individuals, and that's based on research, by the way, but it created these expert panels. And then with the research staff at RAND and with content experts from around the country, we would create a set of possible clinical indications. Now, the indications are really clinical scenarios, right? So you'd think of who's going to come for, say, a hysterectomy. And you think of all the clinical reasons they could present for hysterectomy, and that's a set of indications, and you vary them. So if we take the one that I do, which is on back pain, so you can have a patient that presents, they've got low back pain, no x-rays, no MRI, no pathology, no radiculopathy. Okay, so that's one indication. Is that someone that you might do surgery to or manipulation to? Then you can vary it. So the next scenario, low back pain with neurological deficits. They obviously have got functional limitations. Now, is that one that you would actually do the same thing to or not? So we create clinical scenarios. They're quite sophisticated, and the importance of them is unlike trials, where in a trial, you've got a standard protocol that the physician's got to follow. So in most trials, if you really want to do efficacy, you've got to exclude patients who've got a whole bunch of comorbidities. But if you're in practice, the person that turns up in front of you is going to have a whole bunch of comorbidities. So if you look at the trial, you don't know whether the procedure is going to work with this person with all these comorbidities because they were never in the trial. But in the indications that I'm talking about, scenarios, we would include comorbidities. So we would have them as red flags. So we would throw in, this person's got neurological deficit, or this person's got radiculopathy, or this person's got some pathology. And then we'd throw it in and we'd actually see what difference it makes to your judgment. So this is a situation where the clinical scenarios are much more like what happens in practice, and they're very comprehensive. You can have up to 1,000 of them. As I'll point out in a moment, we had, I think, 250 in the one we did. Anyway, the research staff creates them, and they categorize patients in certain ways, and they usually, the way in which a patient would present to the clinic, so includes their symptoms, their past medical history, and the results of previous diagnostic tests and patient preferences, and where you have them, what are the results of the diagnostic test. And down below there, I'll tell you about what the rule is for the set of indications. The objective is to create lists that are very detailed and comprehensive and manageable, and will cover most of what's going to turn up in the practice, right? They've got to be detailed enough so that the patients that fall into the category are fairly homogeneous. And again, that's one of the things about trials. When you compare one trial to another, quite often the patient population is not homogeneous at all. And here, the categories, we try to create a homogeneous. So if you say that the person's a candidate for back surgery, everyone in that category has got to be a candidate for back surgery. It should be applicable to all of them if they're in that same scenario. They're comprehensive. They try to include all the indications that occur in practice, and a lot of them are just structured logically. So a lot of them may never occur in practice, but if I say to you, well, a patient comes along, they've got low back pain, they've got no x-rays, they've got no diagnostic tests, and they've got no radiating pain, then by logic, the next one is the patient has got low back pain, they've now got an x-ray, no neurological deficits, and no radiculopathy. And then the third one is going to add the next one. Can you see what I mean? You're adding a logical step each time. So once you've got one of these scenarios, a lot of the others are spelled out logically, but they may never occur in practice. You may never see them in practice, or they only occur very rarely. So there's no relationship between the number of scenarios or indications we create and the number of them you'd see in practice, right? So here's what it looks like. Here's the system, right, that we use. We do a systematic review. We do, from the literature and from other experts, we generate a set of indications for doing a procedure with the clinical scenarios. We then create an expert panel of 9. They at home get these indications and they rate for each of those scenarios on a scale from 1 to 9, whether the procedure we're looking at, let's say it's, I don't know, let's say it's vasectomy or something. Is this a patient a candidate or not? From 1 to totally inappropriate to totally appropriate. Then they come together in a face-to-face meeting. We share the findings, so they know what they rated it. They don't know what you rated. They don't know what each other rated, but they know what the group did. And then they re-rate it, right, to see if they can get some agreement about, do they agree on this is a person a candidate or not. And then out of that, we get a set of indications for doing something or not doing something. So then they get to the 6th procedure. We have indications for a procedure, and we've got the ratings of the panel of them. We then go out to a practice. We pull the patient files. We try to find the patients who had that diagnosis or that problem or that health issue. We look at what was done to them, and then we score about whether it was appropriate or not according to those indications. And over a large sample, we can calculate the rate of inappropriate care. So if we're looking at bypass surgery, we can give you because we do it randomly, we can give you a rate of how much inappropriate bypass surgery is being done, or back surgery, or whatever. Not just medicine, it can be in chiropractic or whatever we do it with, we can actually calculate a rate of inappropriate care. And therefore you can then start looking at the policy issues. Well, if there's a huge amount of inappropriate care, maybe it's worthwhile developing a set of guidelines to take care of that, and telling the physicians or whatever, you need to follow the guideline. Or if it's very, very low, if the inappropriate care is less than 1%, it's probably not worth the cost of doing all the guidelines. If it's very, very, very low of inappropriate care, it's not such a big issue, and you won't save a huge amount of money by changing it by making sure you have protocols and guidelines. So that's sort of the background. So here's the RAND method. Expert panel, clinicians, scientists, clinicians get to put their clinical acumen in and they can argue. It's a modified Delphi. There's 2 rounds, one at home by yourself, one in face-to-face. We get a set of indications, and then we rate the amount of inappropriate care. So here's what it looks like, if you like, pictorially, pretty much. I told you in the middle, you look for an average group of patients presenting with that clinical indication to an average US physician in the year in which you're doing the thing. And so that's just really what I've told you. This is another way of saying the same thing. Here's what the rating looks like. It's from 1 to 9. 1 is extremely inappropriate, 9 is extremely appropriate. At the 1, the risks far exceed the benefit, and at 9, the benefits greatly exceed the risks. We have to come up with a definition of agreement, and so the way that we do it, because you're going to get some disagreement amongst 9 people, if in actual fact 2 or fewer panels lie outside of a 3-point range, then we would say the rest are in agreement. So if 6 of them are within a 3-point range, that constitutes agreement for us, right? They didn't all choose the same one, but they're still within the same thing. They either all agreed it was inappropriate or they all agreed it was appropriate, and 2 of them were the outliers, if you like. Disagreement is when 3 or more panels in each extreme. From 1 to 3, there's 3 there, and there's 3 and 7 to 9. So the panel's completely split about whether they think it's appropriate. And uncertainty is when it's neither of those 2, but they're spread all over the place. Here's the rating scale: extremely inappropriate and to appropriate. And then after discarding what I just told you, one high, 1 low, then we look at where they fall. The disagreement, we can, and the funny thing is you can do a sensitivity analysis by playing around with different definitions of agreement, if you like, and we do that as well to see what difference it would have made. And appropriate is when you got a medium 7 to 9 without disagreement, and inappropriate is when it's 1 to 3 without disagreement. So that's, and the other ones that we want to get when we measure the inappropriate care, we want the ones for which there's agreement that it's appropriate, and we want the ones for which there's agreement that it's inappropriate. So here, if you're on this panel and you come to the second meeting, which is a face-to-face one, used to be at RAND before COVID, but anyway, if you come, this is what you get. That little asterisk beside the 7 tells you that's what you chose, and the others, the other thing shows you the distribution of the panel. And remember, 1 was extremely inappropriate, 9 is extremely appropriate. Now this one, you can see they're all over the place. So this was what we call uncertain. Sometimes it's called equivocal, but uncertain or equivocal is the same thing. On this one, they couldn't make up their mind whether they thought it was appropriate or not, right? So you get the medium of the panelist raters. Here we tell you that it's uncertainty because they're all over the place. And if you look at 3, someone chose 3, someone chose 2, chose 4, no chose 4, 1 chose 6, 2 chose 7, 3 chose 8, right? So you can see there's a wide range of opinion on this, whatever this procedure was, to do it or not do it. So that's kind of a very quick overview of what a modified Delphi approach is. This method is the most widely studied of any expert panel process in the literature. We've done a huge amount of work on the validity and reliability of this process. We've looked at the relationship, how well the panel has rated stuff compared to the literature, because you can do that, particularly when you've got good literature, you can actually see, do they follow the literature or not? We've done face and content validity, we've done construct validity, and we've done test retest. The studies that have been done we've compared panels in different countries. So Israel, England, and the United States and Canada, they've all run panels on CABBAGE, I think, and we've compared what the outcome is. we've compared panels occurring at different times, and that's incredible, because if you look at something like angioplasty, the guidelines about angioplasty have changed drastically over the last 25 years as more research comes to question about whether it should be done, and if you shouldn't just go straight to bypass surgery, you would need to update them. So they need to be updated as more information comes. And then we've actually looked at the impact of panel membership. If you're going to look at hysterectomies, you don't stack the committee with obstetricians and gynecologists. If you're going to look at manipulation, you don't stack the panel just with chiropractors. And the reason you don't do that, you know, the old saying that for a hammer, everything's a nail. Well, of course, people who do a procedure for a living are much more likely to vote for it to be appropriate. So Paul Schickel and I did an all chiropractic panel, and then we did a panel where we looked at osteopaths, physical therapists, physiatrists, neurologists, neurosurgeons, and chiropractors, and we compared the results. And of course, since chiropractors do most of the manipulation, they rated a lot more things as appropriate for manipulation than the others did. Although I have to tell you, even there, we had some MDs that did more manipulation than chiropractors did. So the results can be a bit surprising, but we have done that. And then Paul Schickel did a trial retest on this. He did three panels on hysterectomies and 3 on CABG. I'll tell you what CABG stood for if I could remember, but it's got something to do with bypass surgery and angioplasty, and I can't remember what the actual CAGB actually stands for. But anyway, we ran 3 at the same time, and we looked at how stable the judgments were over those panels. They were done exactly the same time, except one of the things that happened there, between 2 of them, a new study came out with new results. So even if you try to run them at the same time, it gets a bit complicated. And so you can see down below that what we've done in terms of, we've actually studied the optimal number of participants on it. We've studied the impact of face-to-face meetings. I've actually videotaped them. I've actually looked at what kind of evidence do they do. I mean, do they really quote the literature, or do they say, well, I don't care, let me tell you what I do in my practice, or let me tell you what I've seen in 30 years. And does that persuade people to change their mind? So we've done a lot of research on this process. So as I said, it's the most research expert panel process that exists out there. So we've got a whole body of literature on it. So now I'm going to change and talk about 2 projects very quickly, if I can. This is one that I've done just recently. Ron was on it, actually. I don't list him there, but you'll see in the publications he's on it. And this was determining the appropriateness, manipulation, and mobilization of chronic low back pain and neck pain. And this is kind of interesting. We did acute low back pain and neck pain, I think 20 years ago. We couldn't say anything about chronic back pain then. There was just no literature. And of course, neck pain with manipulation has always been a major concern. And so, but this project was funded by NIH, as you saw there. It's now called in the National Center for Complementary Integrated Health. But it was actually funded to develop the method to use appropriate studies on complementary alternative medicine. So even though we chose chronic back pain and we chose manipulation, the actual method was to be applicable to the whole of complementary alternative medicine. So we chose the 2, right? The major aim was a 4-year study. It was to look at manipulation and mobilization for both back pain and chronic cervical pain. As some of you probably know, probably the most widespread condition amongst the population is back pain now, and even internationally, I think it now is, but certainly in the United States and things like the Army, the number 1 reason for discharge from the Army is back pain. So it's a huge problem, hugely costly, and of course, given the opioid crisis, we're very interested in looking at non-surgical, non-pharmacological treatments of it. So it actually had 4 R01s in this project. So an R01 is, as you know, an independent study project by itself. The first one's the one I'm going to talk about, which is the one that used modified Delphi. The other 3 went out and collected data on chiropractic patients and practices. And then, I'll talk about that, what we did with that later. But the one that we're going to talk about is the first one. Now, one of the things, this is kind of innovative, because one of the criticisms that was always made of the RAND UCLA method is it only focuses on clinical appropriateness. So if you think about it, it only looks at the clinical basis for judging appropriateness. It doesn't, no patient is on the panel, and they don't ever look at what patients wanted. Their preferences don't count. And we tell them don't take into cost, ignore costs. So you've got to make a decision about whether this is clinically appropriate or not. That's the only decision you're making on those panels historically. Well, as you probably know, through Bakori and that, we've moved into a new era of patient-centered research and patient important incomes. And so that sort of approach now is sort of being criticized. But at the bottom, but still, you have to say that at the very least, you want to make sure it's clinically appropriate. Then you might want to think about what the patient preferences will be. And if you think of, say, prostate cancer, where there's a 3 or 4 alternative approaches you can take to prostate cancer, all of them with fairly serious side effects for the person who does it. If you think of mastectomy, the same thing. You can do radical mastectomy or not radical. So here are 2 instances where the patient preference should count for a lot, because it's going to determine what they actually do. And then, of course, cost should actually be in there. So what's happened in this study is those bottom 3 there, Project 2, 3, and 4, went out and collected data on patient preferences, patient outcomes, and patient cost. And we're trying to get around that weakness, because what we wanted to do was then present that data to the panel as well. So this is how it went. We did a systematic review. We've published both those on manipulation for chronic low back pain and neck. We then did the expert panels. We created the indications, the same as I told you we did in the past. We then got a set of indications for appropriateness ratings. We then went out to the practices and we did several things. One, we calculated the rate of appropriate and inappropriate care by getting a random sample of patient records. And then we enrolled patients, chiropractic patients. We followed them for 4 months. We interviewed them every 2 weeks. So I think that's 8 data points, I think. And we got data on outcomes and satisfaction and preferences and so on, right? And then we abstracted their patient file and calculated the appropriateness of care. Then we reconvened the panel, and this is where this is innovative. We reconvened the panel for a second face-to-face meeting, and we now gave them the data about the patient preferences, the patient outcomes, and the cost. And so now the panel does get real life data from real life patients and real life practices, and not just the results of trials. And so here's what happened here. They completed the first set at home again, just in the traditional kind of manner. Then they reviewed, they came together and they reviewed each other's ratings. They knew what they rated it. They saw what the group did. They then re-rated. That's the second rating. And then, as I told you, we brought them together for a third time. So this one was 3 rounds of the modified Delphi, 2 of which were face-to-face, right? And at the second, as I said, this is what we gave them, the data from those other projects I told you. And on the right just tells you how much data we had. We actually had like 2,000 patients, but we had data on 1,677 good ones, if you like, that we tracked for every 2 months using mainly promise measures, as Ron was one of the ones who developed them, and measuring outcome. We had their patient files. We also did a sample of patients. And then the other thing that we did was crowdsourcing. We enrolled another sample in crowdsourcing. And I think in actual fact, that's at the bottom there. We had 1,500 back pain patients in crowdsourcing, out of which 310 were chiropractic patients. And we compared that sample to the one that we got from going out into practices. We had 5 sites over the United States where we went into chiropractic practices. We would spend several days there. We get all the data we could while we were there. The people we followed online did it online on the computer. And so we have a whole massive body of data to feed back to that panel that for the first time is patient-centric and isn't just trials and from the literature. This is what a set of indications look like. So I told you the clinical scenarios. So this would be a chapter 7. So up the top there, it tells you we're looking at spinal manipulation and mobilization is appropriate for chronic low back pain. And on the right, they've had no other adequate conservative care. They haven't tried anything else conservative for this episode. And they have, and the non-manipulative conservative care has failed. So usually that means they've been to medical, they've tried drugs or something, or they've tried physical therapy, it didn't work, and they've come in to get manipulated, right? And they can be mobilized and manipulated. And then here's the clinical scenario. So this is the category of patient that you're dealing with on this one, right? They've had prior mobilization and manipulation. They've had favorable response. So they've been manipulated before. They've still got pain, but it's diminished. They've got spine radiographs. They show no contraindication, so there's no pathology. There's no imaging studies other than that. I think that's something to do with hips, but I could be wrong about that. There's no spinal stenosis. There's no neurological findings. You don't have any neurological findings. And it does have sciatic nerve irritation. And then physical findings indicate if they've got joint dysfunction. So all of those things put together is what this patient's presenting. And you've got to decide, will you manipulate them or mobilize them or not? And you do it on that 1 to 9 scale, right? So you either say they're extremely, you might say, well, you know, I don't know, maybe you think the x-rays show that it shouldn't be done or something. Whatever it is, you can rate it as either extremely appropriate or in the middle, or you don't know, or it's extremely appropriate. So that's what the system looks like, right? They had 450 indications, so that's a lot of indications. So that's 450 patient types, if you like, scenarios. The rate of agreement is 23% above all of them. You can see, I won't go on the results, you can see we have the results, and we calculated the rate of inappropriate care. It turned out in this study, the rate of inappropriate care from the data from the practices was about 3%. It's the lowest I've actually seen in any study I've done. But anyway, interesting enough, which is a sort of footnote here, most of them seem to favor mobilization over manipulation, which is kind of interesting because I can tell you in the literature, manipulation has better outcomes and is more effective than mobilization and actually has less adverse effects. So if you're going on the literature, you'd actually favor manipulation, not mobilization. But it seems to be that in most people's mind, including those of chiropractors, mobilization looks like a lot safer to them than manipulation does. Well, it turns out the trial literature doesn't actually support that, believe it or not. This is the chronic neck pain. This was extremely important because neck pain manipulation is always a huge issue. As it turns out, often the issue is exaggerated. The number of truly adverse events from neck pain is actually, from manipulation, is very low. Anyway, so I won't go into further there. There's the 2 systematic reviews, and I'll just sum up by saying, historically, it was strictly a clinical decision. What's innovative about this last study is trying to make it patient-centric, and by feeding information back in about patient outcomes in real life practice, not trials, and with clinical indications of the sort of person who's likely to turn up in practice that you would actually see with all the comorbidities and things, trying to find out what are the red flags for not doing it, and also trying to make sure that patient preferences could be factored in, outcomes could be factored in, and maybe costs. We did an incredible cost analysis of 22 different modalities you could use. And I hope to stop in about 5 minutes. So the next study then, going very quickly through this, is one that Dmitry Kotakov at RAND was the PI on, and that I was on as well, and a lot of others. It was a PCORI project, which means it had to be patient-centric. As you know, PCORI is Patient-Centered Outcome Research Institute, I think, yeah. So any research that PCORI funds has got to be patient-centric. And so they were quite interested. And this was one to try and find out, to get a patient-centered approach to guidelines for the treatment of Duchenne's disease. And as you know, patients don't usually get to participate in guidelines. I told you in the one that I just gave you, we used a modified Delphi, but pretty much the way it's always done. This one used expert lenses. Now, funnily enough, this was before COVID-19, but now this is probably how we'd have to do it. Expert lens and an online method for collecting data, very good one, actually. I won't go into the actual methodology of that. You can look it up, but it's a process of online engagement. The advantage of it, you can enroll a lot more people than 9. So you can have a much big stakeholder. This is what they were trying to do. They had an eye generation. They then wanted to generate from that and from the experts and so on, a set of guidelines for treating Duchenne's patients. They then wanted to rate the importance and acceptability of those recommendations to stakeholders, which I'll tell you who they are in a moment. Then they got feedback and discussion. Then they redid them. And in this case, I think they might have had 3 rounds, I think it was. So it looks like this. Round 1, they get to look at the guidelines that have been proposed for the treatment of certain things related to Duchenne's. They score them 1 to 9, the same as they did. So like that, it's like the same as the modified Delphi. Then they get to see all the results. They have a discussion. They then get to share why they rated them the way they did, but they get to say, is it important? And do they sort of support it? Then round 3, they go back and here they share the thinking. And the one thing that's unique about this as well, unlike the one I just gave you, in the one that we do, the expert panel, you don't know what the panelist is thinking. You just know what their ratings are. You don't know what went into their thinking, right? Here, they did try to explore their thinking. So here's what they did. They enrolled patients and they enrolled parents and caregivers. Sometimes it was caregivers, people taking care of the child particularly. And you can see the numbers. They actually randomly attributed them to different panels and they varied it a little bit. So it was kind of experimental. But anyway, it's a very interesting study. But what's really interesting about it is this part here, what they did with the modified sort of Delphi system. Up the top, you can't read it very well, I know, but that's one of the guidelines, right? This one had to do with somebody with spinal health or something, I think. Down below, here's where they do the 1 to 9 ranking, and they rate it as either very important, right, or not very important, right? And then secondly, they're asked, is it acceptable? So even though they may feel it's important, they may feel it's not acceptable. Their parents won't do it, or the patients won't do it, or whatever. So there's 2 things that they're rating here. And then down below there, we ask them what factors affected their decision, right? Now, when they've done, after round 2, of course, now they've seen everyone else's ratings and they've actually got to see the qualitative data about what everybody said about why they did it, right? So here's what they get back. That little red dot on 2 says that's the one I chose. Blue line tells me what the mean is. This one was about using hormone therapy. It turns out that one of the problems for males for Duchenne's is delayed puberty. And so the question was, I think if you saw it all, about whether they should use hormone injections to offset this. And then on the right, you get to see the reasons. So if I'm on this panel, I get that little chart thing and I get those reasons up the top, and then I get to re-rate it, right? And then I can see. And this is what it looks like, you see? This one's not telling me now what I do, but this is the kind of data they get back. Very visual, very interesting, and patients and the parents seem to find it quite easy to do this. And people didn't drop out, they kept in. Now, of course, Duchenne's people, stakeholders, have a very high interest of being kept in, because there's huge issues around guidelines and so on. But you can see we give them examples on the right of what would get you a low rating, right? Why there would be a low rating. And that's because it's not necessarily because there's no apparent delays, that someone thinks, well, you know, they don't see any delayed puberty, or there's more important concerns than that. And if you look down the bottom, this is somebody who thinks it's really important that boys want to be part of their peer group, and all the others are going through puberty and they're not. it makes them feel more of an outsider than they already are as a Duchenne's patient. So that's the sort of thinking you can get. And you can see, you can really do quite sophisticated stuff here. And that was a big panel. That was 95 and something, you know, that's over 100 people that were on this one, whereas we only have 9 on the ones of the other system. So is it important? Is it acceptable? The implications, again, this was very innovative, I think. It's important because it really not only is it centric, it increases the amount of shared decision making. It tries to incorporate the parents and the patients. A lot of Duchenne's patients are too young to participate, but a lot of them are teenagers, you know. It starts early, but it does affect teenagers a lot. So a lot of them are certainly capable of participating. I went to one of the face-to-face meetings that had nothing to do with this part, but had to do with some ethical issues. And you know, they're very articulate. They're very clear about what they want to do. So it does increase shared decision making. So it meets the standards of PCORI quite well. So what's the innovation? They used RAM to develop the guidelines. So the same way that we always do it with the RAND UCLA method, they used both patients, caregivers, and parents in developing the guidelines. So that's original. And they use expert learners to create an online user-friendly modified Delphi to do the guidelines. So you can see that's 2 quite different approaches. I've given you some references that you can look at. As I said, we have actually on that one, the first one that I did on manipulation, we published 5 papers. We've published like 27 papers altogether, but 5 papers deal with each part of the method. So if you want to see any of the methods on that project, there are 5 papers. There's one on abstracting from patient files. There's one on recruiting clinics. There's one on the promise outcomes and what measures did we use. So on each step, and we actually describe how we went into the practices and got the data. So if you want to see how you do that kind of piece of research, we've actually published the methods on each part of it. And there's 5 of them, I think. It's a series. Okay, then that's what I want to stop because I said I'd give you time to talk. And it looks like I didn't do that very well. So can we get out of that now?
Yeah, people can go ahead and ask questions.
Yes. Yeah.
I had a question if no one else has one. So I was interested in the panel and the clinicians, and you mentioned that that there's a lot of there's good retest reliability, and that the methods have been used in other countries, and there's consistency in how different clinicians rate the appropriateness. Have you found if there's systematic differences between sort of physicians that take care of maybe patient populations that are experiencing more like exclusion from the healthcare system or have more trouble with access to care? And perhaps, you know, I'm thinking about patients maybe that are insured through Medicaid, and maybe those clinicians face much more prior authorizations or like administrative kind of friction to getting their patients care, if they're more likely to almost uprate indications as appropriate?
Great question. I can't say that I've ever seen one done like that, except to say that the way we choose the panelists, though, is kind of interesting. And I should have touched on that, I suppose. They're not there to represent any group or organization. So we wouldn't go to the American Medical Association, could you nominate someone? What we try to do is choose people that are going to meet this problem in various parts throughout the healthcare system. So by logic, there will be people on that panel that exactly fit the description you're talking about. I don't know anyone that's actually done it to make sure the panel itself was overwhelmingly of that sort, but in the panels, because of the way that you choose people, you would actually be choosing somebody that's probably in that situation, right? So there will be, so to give an example, I'll take hysterectomies again, because it's a good example that we did. We ran 3 panels on it. We would make sure on that panel, there are providers that are going to confront the problem about a hysterectomy with a patient at anywhere in the healthcare system, underserviced population, overserviced population, whether it's a GP, whether it's actually an obstetrician, a gynecologist, whoever's likely to encounter that as a problem coming into the front door, we would like to see them on the panel. So a huge amount of work goes into choosing the panel, but I can't say I've honestly seen any panel chosen for what you're talking about. But I would tell you that given the huge interest at the moment in structural racism and the request for proposals that's coming out of NIH, I'll almost bet we will see some. I always think you're going to see some. I think it's a great question, Carlos. Yeah, very good. But I can't say I've honestly seen anyone. And even if the people on the panel, I've not seen any separate analysis. There wouldn't be enough of them, because if you did the analysis, everyone know who it was, right? So, you know.
I have a question.
Mm-hmm.
Thank you so much for the talk today. I'm a neurosurgeon and spine surgeon, and during my fellowship, I did present one of the papers out of UCLA RAND for degenerative scoliosis and appropriateness for different surgeries. And I have to say it was accepted with kind of mixed feelings and looks on their face when I brought up all the tables and talked about it. So my question to you is, how do we get from all these different scenarios that you said, 460 in some cases, how do we get that back to the clinicians in real time so that they can utilize the appropriateness score?
Yeah. Rand spent a lot of time. I mean, this is his whole thing about, how you get change. I mean, how do you bring about change? And the problem with the NIH panels is they didn't seem to ever do that. I actually think that the way that you get a lot of change is to be able to show how much inappropriate care there is. I think, when you've got 36% of a procedure that's inappropriate, I think that starts getting clinicians' attention, right? And if you can document that that's the case, then the next step is, okay, what do we do about it, right? I think when you don't have that attention getting, trying to get guidelines developed or getting people to follow them. Now, if you're at Kaiser, it's okay. Kaiser adopts guidelines and you follow them, right? Presumably, right? I assume that's what you do. But I think you raised a great issue. I think the whole reason this came about was the fact that Rand had discovered that clinicians were not being influenced by those NIH panels. It wasn't having any impact on practice, right? And so I think you ask a really great question, and that's really the next step. How do you get change? I mean, and this is why the transformation, and there's a huge amount of work on this now. Translational science is the big field, as you know, right? But how do you get that into the gestalt of those on the front line practicing, right? And it can't always be guidelines. It takes a lot of money and effort to develop guidelines, right? And I can see why that's worth it when the problem is huge, right? And when the costs are huge. But when the problem's still important but not huge, how do you get the directions then? Is that sort of answering what you're asking here? I will tell you that I have a lot. I mean, I don't know how well it's going to work out, but at the moment, the big hot field is translational science. And that really is about how do you take scientific evidence, how do you take scientific discovery and translate it into practice, right? We know continuing education is almost useless. Funny enough, there was a lot of good research done on this that compared continuing education. Do you know what the social influence model is? Well, it turns out there's a thing called detailing. I mean, the way that you can try and change physician behavior is continuing education. And that really is just bum and cheers, to be quite honest. They got to sign in and sign out, and they prove that they've done the continuation for an hour, and they get a CME for it, right? Totally useless, right? The second one was to copy the pharmaceutical companies and do detailing. And detailing is what happens when a drug representative comes around to your practice and he's got all these beautiful charts and things and you go through it. That turns out, as we know from the opioid crisis, can actually be quite influential. In fact, it was highly influential. with the drugs and the opioid crisis. But anyway, the third one that's shown to have the most effect is called the social influence model, where you get physicians to identify who they respect mostly, who's a thought leader, and you get that thought leader to come in and work with you developing a program that then will change behavior. And it turns out, at least the early research, and I haven't looked at this for several years now, but when I was doing this about 10 or 15 years ago, the social influence model turned out to be the most effective.
All right, so Dr. Coulter, thank you so much for speaking to us. This is really interesting, and I love you're passionate about the work that you've done. Like Beta said, thank you for a wonderful seminar. And everyone, please fill out the evaluation that Anais put in the chat, and we'll send those back to Dr. Coulter. So.
And I apologize about the lack of time for the questions. Funny enough, I was trying to look at my watch and I couldn't see it.
Yeah, no worries. No problem. So.